Okay, let's dive right into this explainer by setting some ground rules. In the high stakes reality of hematological emergencies, the absolute most intuitive clinical decisions can actually be the deadliest. When the ICU alarms are blaring and the labs are plummeting, your very first instinct is usually to treat the most obvious number on the screen, right? Well, today we're going to look past those superficial symptoms. Think about it like this. Completely different physiological crises can present with identical superficial symptoms, and misreading them, it's a fatal trap. If we don't map out the exact kinetic roadmap of what is literally happening inside the blood vessels, the very treatment meant to save the patient could be the thing that pushes them over the edge. Here's our roadmap for today. First, the coagulation dilemma of HIT. Second, the rheological emergencies of blood sludge. And finally, the temperature-dependent destruction in hemolysis. Let's get to it. All right, Section 1, heparin-induced thrombocytopenia, or HIT. Normally, too much heparin means excessive bleeding, right? You just manage it with protamine. But in HIT, we run into a terrifying paradox. A patient on heparin experiences a massive platelet drop, but they aren't bleeding, they're clotting. This is the ultimate 50-50 dilemma where you absolutely have to rely on a 4T score audit. Why? Because an immunologic reaction creates IgG antibodies that bind to heparin platelet factor 4 complexes. They cross-link the FcγRIA receptors and boom, massive systemic platelet activation. The patient literally becomes a walking clot. So the tipping point here is chronology. You have to distinguish between type I and type 2 HIT. Type I is a non-immune, transient drop that happens within the first 48 hours of exposure. It's just a direct platelet aggregation thing that usually resolves. But what happens if you hit that 5 to 10-day window? That's type 2 HIT. That's the immune-mediated catastrophe. That 5 to 10-day window is your absolute danger zone. And here's the clinical trap. Day 6 rolls around, you note the platelet drop, and you correctly identify type 2 HIT. You immediately kill all the heparin. But the patient is incredibly hypercoagulable, so you need a long-term oral anticoagulant. So, why is reaching for warfarin right now an incredibly terrible idea? Because doing that is a notoriously dumb mistake. Warfarin rapidly depletes protein C, which is your body's natural anticoagulant, way before it actually clears out the prothrombin factors. By giving warfarin immediately, you are taking a hypercoagulable patient and throwing them off a cliff into an even deeper prothrombotic state. This directly precipitates acute venous gangrene and horrific skin necrosis. To safely navigate this kinetic roadmap, you have to follow the steps. Stop the heparin, obviously, but then you must bridge the patient with a non-heparin agent, like argatroban or fondaparinux. You have to achieve full therapeutic anticoagulation with that bridge first. Only then is it safe to commence warfarin. Okay, moving into our second module, blood sludge. We're looking at the actual physics of the blood itself. The diagnostic dividing line here is purely mechanical. On one side, chronic lymphocytic leukemia, or CLL, produces small, mature, non-sticky cells. But on the other, acute leukemias like AML pump out massive, incredibly sticky, immature blast cells. We're not just looking at a high cell count on a lab readout. We're dealing with a totally different mechanical object. Just look at the sheer size of these leukemic blasts. They have unclumped chromatin, they take up massive amounts of space, and because they're so large and sticky, they literally act like physical plugs clogging up the microvascular beds of the body. Which brings us to a really high-stakes question on the wards. Why do we completely panic over a 200,000 blast count in an AML patient, but kind of just monitor that exact same total count in a CLL patient? Because treating it as just a lab abnormality is a fatal mistake. This isn't hyperviscosity syndrome, which is driven by macromolecular plasma protein overload, like those massive IgM pentamers and Waldenstroms that cause mucosal bleeding and retinal sausage linking. No, this is leukostasis, a totally mechanical emergency. Those sticky blasts sludge up the brain and lungs, causing severe tissue hypoxia. And here is a huge bonus dumb mistake. If this leukostasis or hyperviscosity patient is anemic, do not just casually order a routine packed red blood cell transfusion. Pumping packed cells into an already sludged vascular circuit will exponentially increase their blood viscosity. You will literally precipitate an immediate ischemic stroke or pulmonary failure right there on the spot. To save your patient's brain and lungs, you have to respect the mechanics. Monitor closely for breathing and neurological deficits, initiate hydroxyurea to drop the white count, and use leukapheresis to literally machine wash that sticky cellular burden right out of the blood. Let's move to our third and final minefield, autoimmune hemolytic hemolysis, where temperature dictates the architecture of destruction. Not all immune hemolysis is created equal, right? The tipping point is the antibody class and the temperature kinetics. Warm autoimmune hemolytic anemia is driven by IgG targeting red blood cells at 37 degrees Celsius, normal body temp, yielding extravascular spherocytosis and a DAT test that's positive for anti-IgG. But we're focusing on the cold today. While paroxysmal cold hemoglobinuria is driven by IgG, cold agglutinin disease, or CAD, is driven by IgM, where the DAT test is strictly positive for anti-C3. Let's zoom in on CAD. These are massive IgM pentamers. They activate in the cooler, distal parts of the body under 30 degrees Celsius. That is exactly why you see patients with blue fingers and toes. Down in those cold extremities, the IgM binds to the red blood cells and permanently fixes complement, specifically C3b. Now, when those coated cells return to the warm central circulation, the IgM actually falls off. It dissociates. But the damage is completely done. That C3b complement is permanently glued on. And as these cells pass through the liver, Kupffer cells detect that complement and just destroy the red blood cells, leading to severe chronic anemia. So here's your final trap. You see the immune system destroying the blood. Your training probably screams, autoimmune inflammation equals steroids, or maybe take out the spleen. So shouldn't we just hammer this patient with high-dose corticosteroids? Nope. That is a perfectly logical but incredibly dumb mistake. Corticosteroids and splenectomies work wonders for the IgG-mediated destruction in warm AIH because that destruction happens in the spleen, and splenic macrophage are suppressed by steroids. But they provide absolute zero clearance for cold agglutinin disease. Why? Because CAD destruction happens in the liver, not the spleen, and IgM production couldn't care less about steroids. It is completely unaffected. So skip the useless steroids. You manage the thermal kinetics directly. Focus strictly on cold avoidance. Keep the patient physically warm so the IgM never binds in the first place. Then you target the underlying plasma cell disorder with therapies like rituximab, or use plasmapheresis if those IgM proteins are causing hyperviscosity syndrome. Okay, let's wrap this all up and synthesize how we actually survive these treacherous scenarios. The absolute crucial takeaway from today's explainer is that you have to look past the superficial lab values and map the exact kinetics. Respect that 5 to 10 day immune window of type 2 hit and bridge with argatroba-N. Understand the literal stickiness and size of leukemia blasts before you accidentally transfuse a patient into a stroke. And respect the thermal axis of IgM antibodies so you don't prescribe useless steroids. So I'll leave you with this provocative thought. The next time the alarms go off in the ICU and you see plunging platelets or a spiking white count, are you going to fall for the intuitive trap? Or are you going to stop, read the tipping point, and actually treat the underlying mechanism? Understanding the why isn't just academic. It's the only way to get your patient out of the minefield alive. Thanks for joining me on this explainer, and keep questioning what you see.